Assalamu alaikum. In continuation with my previous lecture about the pharmacology of the anesthetic agents, today I'm going to tell you something about neuromuscular blocking agents and the local anesthetic agents. Neuromuscular blocking agents. As the name suggests itself that we are talking about certain drugs which are going to block the normal neuromuscular action. I hope that most of you find this picture as very familiar. This is the picture of a neuromuscular junction that is formed by a nerve terminal, that is the axonal terminal, and also with the muscle membrane. You can see over here that this is that the axon of the nerve. It will form a neuromuscular junction with the muscle membrane, and you can see that the I don't know why the pointer is not working, but the axon terminal contains lots of mitochondria, and it contains the vesicles that contains the neurotransmitter that is used to function to work at the neuromuscular junction known as the acetylcholine. Acetylcholine is basically formed by the combination of the acetate and the chlorine by the action of an enzyme that is choline acetyl transferase, and after formation it will uh, be stored in vesicles, and these small vesicles they are present in the axon terminals, and they remain over there stored as such till some nerve impulse, some excitation occurs, and an action potential is generated. Whenever a nerve impulse or stimulus comes, then there is going to be change in the action potential of these axon terminals, and it will cause release of these acetylcholine uh, from these vesicle into the gap that is present between the axon nerve endings and the muscle membrane that is known as the neuromuscular junction cleft. That gap is known as the cleft. Then it will act on certain receptors which are present on the muscle membrane, and these are the postsynaptic acetylcholine receptors. It will produce certain changes in the uh, post-junction receptors, and these receptors, basically acetylcholine receptors, they are made up of certain uh, subunits known as the two. There are two alpha subunits. One is beta, another is the delta, and one is E, that is the epsilon. In the fetus, this epsilon is replaced by the gamma subunit. So these are proteins. These receptors are basically proteins which are located in the muscle membrane, and whenever acetylcholine is going to be released from the prejunctional sites from these vesicles, it will enter into the cleft, and it will unite with these postsynaptic receptors, and it will produce certain changes which we will see in a while. And these receptors, they are basically channels. These channels, they are going to open, and they produce the transfer of the certain ions like sodium and potassium in and out of the cells, and that is so that these muscle blocking agents or the acetylcholine they can act. This is the normal phenomena that occurs at the neuromuscular junction, in which the acetylcholine is formed. It is going to be stored in certain vesicle. Whenever a nerve impulse comes, then it will cause release of the acetylcholine. This acetylcholine will combine with the postsynaptic receptors, and it will produce certain changes in these receptors, and it will cause opening of these receptors channels, and some ionic concentration gradients they will develop, and this will produce the effect of the acetylcholine on the muscle membrane, and this is of course the contraction. This is the normal process in which the muscle fibers they contract. This is another elaboration of the same thing which I shown you earlier, in which you can see that there is axon terminal is there with lots of mitochondria, and then there are vesicles which are stored in clusters, and hundreds of clusters are there of vesicles. Whenever there is change in the action potential and there is depolarization, then there will be a release of these acetylcholine vesicles. They release their contents into the uh, cleft, junctional cleft, and then it is unites with the receptors, postsynaptic receptors, which are the present, the nicotinic receptors, which are present at the postjunctional membrane, and then they will bring about the contraction of the muscle. So this is the normal anatomy and physiology of the neuromuscular junction. Role of mitochondria is very important because this contraction requires lots of energy. Another very important thing which I want to tell you at this stage, that this release of acetylcholine from the axons, from these vesicles, needs calcium ion. This calcium diffuses from this cleft into the uh, prejunctional part of the axon, and then it will cause release of these acetylcholine uh, neurotransmitter. This is the picture of the post-junctional acetylcholine receptors, where you can see that it is made up of certain proteins and which are having some subunits, two alpha subunits, one beta, another is delta, and the other one is the epsilon or gamma. Gamma is only present in the infants, and the acetylcholine, it will unite with these two alpha subunits. It only unites with these two alpha subunits, and then it will, you can see from here that the acetylcholine, it is coming, it is released from the neural end, and it will uh, come and unite with the nicotinic receptors present on the muscle membrane. These are the receptors. This is the acetylcholine. It just fits into it, and then it will open these ionic channels. It will only unite with the alpha subunits. It will open these channels. The sodium will go inside of the cell, and potassium will go outside of the cell. And this will produce the depolarization and repolarization. You all know that the neuromuscular at the neuromuscular junction, the action potential is slightly negative, is around minus 90 millivolt. When the depolarization occurs, it just shifts slightly due to the influx of the sodium towards more positive side. When then the time comes when this influx of the sodium stops, and then the outflux of the potassium starts, and this will cause repolarization. Once the impulse, the action potential subsides, then again the sodium will go out and potassium will come in, and the normal resting membrane potential is going to be stored. How these neuromuscular blocking agents work, now let's see that. So this is a normal depolarization process in which the acetylcholine, it is released from the axonal nerve terminals. They will come in the cleft, where they are going to be attached with their post-junctional acetylcholine receptors, and then with the only with the alpha subunits, only with the alpha subunits. You can see over here how it is causing changes. Then this sodium channel opens, and there is going to be entry of the sodium, influx of the sodium into the cell, and this will cause depolarization. This is the normal phenomena, normal depolarization. What happens when we use neuromuscular blocking agents? There are two types of the neuromuscular blocking agents. One are known as the depolarizing agents, other are known as the non-depolarizing agents. The most common example of the depolarizing agent is the succinylcholine, that is made up of two acetylcholine receptors. Now, as it is having the same formula, because it is made up of two acetylcholine molecules, then this will come and unite with the receptor. Instead of acetylcholine, the succinylcholine will unite with the receptors, and it will produce confrontational changes, and there's going to be opening of the sodium channels in the same way, in the very same way the sodium channels are opened, and it will produce depolarization. That's why these drugs are known as depolarizers. Depolarizers because they cause depolarization, entry of the sodium, and in the same way as the normal acetylcholine uh, produces its effect. But the action is slight bit long, because the effect of the acetylcholine persists for a very small period of time. It persists only for 1 millisecond, and then it is going to be breakdown by the acetylcholinestrases into acetate and choline. While the succinylcholine, it is not going to be metabolized by the same enzyme. That's why it, its action remain for a longer period of time. If we talk about other agents which are known as the non-depolarizing agents. So here is the acetylcholine, the same post-junction receptors, but now the agents which are known as the non-depolarizing agents, they act as basically antagonists. They do attach with the receptors, but they will not open the sodium channels. They do not cause depolarization to occur. So for acetylcholine and for the depolarization blocks, we need attachment of the drugs, acetylcholine or the depolarizing agents with the receptors, and they always open the sodium channels, by which the sodium goes inside and produces depolarization. But when we are talking about non-depolarizing agents, they do attach with the receptors, but they do not open the channels, sodium channels, and that's why no depolarization takes place, and they are known as non-depolarizing agents. So if we talk about the ideal qualities of the neuromuscular blocking agents, the most preferable are the non-depolarizing mode of actions. They must be rapid onset of action and short duration of action. There must be no cumulative effect. Cardiovascular effects, they are again, though they are produced by certain non-depolarizing agents, but again, they must be minimal. Histamine release and another problem that is seen mostly with the neuromuscular blocking agents. So we prefer drugs who are concerned with least release of the histamine. Then the drugs which are having spontaneous or predictable reversal, they are preferred. And the drugs which are highly potent and with inactive metabolites, they are preferred. If the person is suffering from renal or the hepatic disease, either we use drugs which are devoid of these renal or hepatic metabolism and excretion, or we use to titrate their doses. Basically, as we just I told you that they are divided into two kinds of the neuromuscular blocking agents. One are known as the depolarizing agents, other are known as the non-depolarizing agents. Depolarization agents are those which most commonly is the succinylcholine or succinylcholine, which causes depolarization in the same way as the acetylcholine. They will open the sodium channels, while the non-depolarizing agents are those agents which are which do not cause depolarization, and uh, they are again divided depending upon their chemical structures into two broad groups. One is known as the aminosteroid, and the other is known as the benzyl isoquinoline esters. The examples of the aminosteroids, they are pancronium, peppercornium, procronium, and vecuronium. While benzyl isoquinoline, the most famous which we use are atracurium and cis-atracurium, which are widely available in Pakistan. Other are the doxacurium and the mevacurium. We can also classify these neuromuscular blocking agents in another way. One is short acting, intermediate acting, and long acting. If we talk about the agents which are short acting and they are depolarizing, then the drug is succinylcholine or succinylcholine. While if we are talking about the non-depolarizing short acting, gentacurium is available, but it is only available in the experimental studies so far. So most commonly used are the intermediate acting drugs like atracurium, cis-atracurium, vecuronium, and rocuronium. Long-acting agents like pancronium, they can also be used for the procedures which are prolonged. If we talk about the sequence of paralysis caused by these neuromuscular blocking agents, then first of all, the small muscles of the eye and the fingers, they are going to be paralyzed. So it means they are mostly affecting the limbs. Then it will affect the trunks. Then it affects the muscles of the neck. Finally, the intercostal and the diaphragm. So diaphragm is the last muscle that is going to be paralyzed by these neuromuscular blocking agents. If we talk about the recovery, then this process just reverse. So first of all, diaphragm is going to be recovered from the effect of the neuromuscular blocking agents, then intercostal, then neck muscles, then trunk, then limbs, and finally the finger or the small muscle of the eyes. They are going to be reversed. So you must remember the sequence of paralysis and sequence of recovery. Over here you can see the pharmacokinetic uh, properties of these drugs. Succinylcholine, that is comprised of two molecules of acetylcholine. It is going to be metabolized by the plasmacholinestrases or the pseudocholinestrases. Acetylcholine, as I told you earlier, that is going to be immediately within 1 millisecond is going to be metabolized at the junctional cleft by the uh, acetylcholine esterase that is present in that junctional cleft. But the drugs which are depolarizing agents or non-depolarizing, they are taken up from the cleft by the blood. They will enter in, it will enter into the circulation and then it will go undergo metabolism. Mevacurium and succinylcholine, they are going to be metabolized by an enzyme that is present in the blood known as the pseudocholinesterase or plasmacholinesterase. While some drugs, they undergo metabolism into the liver and they are excreted from the kidneys. So we must be very conscious in the persons who are having renal dysfunction or the hepatic dysfunction. If we talk about the atracurium and cis-atracurium, which we use widely in our setup also, they undergo Hofmann's elimination and they are also metabolized to some extent by the plasma esterases. Hofmann elimination is a special kind of metabolism in which they are metabolized. Metabolism is dependent on the body temperature and the pH of the blood. If the body temperature is high, then they are going their elimination, their metabolism is very much increased. Most of the drugs, they neuromuscular blocking agent, they have very few secondary metabolites. But atracurium and cis-atracurium, they have a very important metabolite that is known as the lidonosine. If they are given in repeated doses or for a prolonged period of time, then this lidonosine is going to be collected into the blood and it is harmful for the CNS and renal function also. If we talk about the pharmacokinetics in a broad term, then depolarizing muscle relaxants, they act as acetylcholine receptor agonists. We just talked. Whereas non-depolarizing muscle relaxant function as competitive antagonists because they do unite with the receptors, but they will never ever open the sodium channels, and they are not responsible for the induction of the depolarization, because depolarization muscle relaxants are not metabolized by the acetylcholine stages, so they diffuse away from the neuromuscular junction, and they are hydrolyzed in the plasma and liver by other enzyme known as the pseudocholinesterase we just talked about. So you must know that acetylcholine is going to be metabolized at the junctional cleft, while the other muscle relaxants, including succinylcholine, it is going to be taken through the blood into where there is going to be metabolized by the pseudocholinesterase, or they are metabolized by the liver. Reversal of non-depolarizing agents blockade depend on redistribution, gradual metabolism, and excretion of the relaxant by the body. Or sometimes we administer specific reversal agents for non-depolarizing agents, which are known as cholinesterase inhibitors, and the most common example is the mustigmine. These cholinesterase inhibitors, they will inhibit the acetylcholinesterase enzyme activity, and they will reverse the effect of the neuromuscular blocking agents. Another new drugs known as sugamadex is used, another reversal agent that is going to be combined with the rocuronium and vecuronium, and it will form a complex that is going to be excreted out. So it will reverse the effect of rocuronium and vecuronium only. It is a selective reversal agent. So basically, depolarizing agents, they are going to be metabolized by the plasma cholinesterases and the liver, while the non-depolarizing agents, they are actually, they need a reversal agent. Succinylcholine is a very important depolarizing muscle relaxant, because it contains two joint molecules of acetylcholine. So its effects and paralytic properties, they are very similar to the acetylcholine. In certain patients, because it is metabolized by the pseudocholinesterase, in certain patients, they have either low levels of the pseudocholinesterase, or there is genetic atypical enzyme is present. In certain patients, it is heterozygous atypical enzyme, and in some patients, it is homozygous atypical enzyme. In cases of the heterozygous atypical enzyme, block duration is doubled or tripled. The maximum duration of action of the succinylcholine is 10 to 15 minutes. But if the patient is having genetic problem the uh, pseudocholinesterase enzyme present in the blood, then the duration is going to be either 30 minutes or maximum it is 40 minutes. But if the patients, they are having homozygous abnormal enzymes, then the patient can suffer from a very long duration of the succinylcholine, and instead of only 10 to 15 minutes, they develop paralysis for 4 to 8 hours after the administration of the succinylcholine. And this is the question that was asked by a student in my previous lecture, that madam, some patient they do not recover from the anesthetic agents, और उनको कहते हैं कि जी वो कोमा में चले गए हैं और वो बेहोशी में से जाग नहीं रहे हैं. But the answer is that बेटा, कि inhalational agents and the intravenous agents, they will remove from the body by their metabolism and excretory processes. They do not last longer in our body. The agents we are having nowadays, they are very safe agents. It is only the succinylcholine, if given in the patients who are having homozygous atypical enzyme, then they can suffer from a longer duration of blockage, and this is again can be managed by the anesthesiologist. It only requires management of the airway and ventilation. We continue to ventilate that patient for 4 to 8 hours till the complete metabolism of or removal of succinylcholine, and the patient wakes up without any residual side effects. Another management is that the patient can be infused with the FFPs, which contain these pseudocholinestrases. And again, it is going to be metabolized, it is going to remove or metabolize that succinylcholine that is present in the blood of the patient. So, the only management in the patients who are having prolonged paralysis after the injection of the succinylcholine is to wait and ventilate the patient. Um, this succinylcholine is mostly avoided in infant patients, in the patient who are having history of myopathies, or there is family history of malignant hyperthermia, or the because of various, and in also in the burn patients, because succinylcholine, it has the quality of increasing the potassium into the blood for up to zero point 0.5 milliequivalent per liter. But in case of myopathies or in burn patients, it can increase the potassium to many folds. Even it can increase up to 12 milliequivalent per liter, and that can cause the one of the cause of the hyperkalemia that can lead to cardiac arrest. So if the patient is having the history of myopathy, if the patient has suffered from burn, then we must be very cautious in using succinylcholine in those patients. And it also causes that produces effects on the heart. It can cause the atrioventricular nodal rhythm, it can cause ventricular arrhythmias, and it can result in bradycardia also. It is associated with the rhabdomyolysis for the allergic reactions. It increases almost all the pressure. It increases the intraocular pressure, intragastric pressures, and intracranial pressure. So it's used in headache patients suffering from head injuries, or in patients who are having some eye problems, or who are full stomach patients is must be very cautious. But again, on the very other hand, because it's very rapid in action, so it is the drug of choice for the rapid sequence induction in patients who are considering, we are considering them as full stomach and they are undergoing anesthesia for these emergency surgeries, and we do not want them to aspirate the gastric contents. We use a typical type of general anesthesia that is known as the rapid sequence induction. This rapid sequence induction we will study when we will when I will teach you the practical conduct of anesthesia. Then you will see the how we prevent this the aspiration of the gastric contents. But the succinylcholine is used in that rapid sequence induction, and this succinylcholine is associated with the raise of the intragastric pressure. But how we overcome this problem, I will teach you in coming upcoming lectures. Then, if we talk about the adverse effects of the non-depolarizing neuromuscular blocking agents, so the first agent that was the non-depolarizing neuromuscular blocking agent was the tuberculare. It blocks the autonomic ganglion. So it compromises the ability of the sympathetic nervous system to increase the heart contractility and rate in response to hypotension and other intraoperative stresses. So actually, it camouflages, it masks the sympathetic effect, and if the anesthetist is not vigilant, then it can cause a problem. But the tuberculare is not used nowadays. Pancuronium and galamine, they block the vagal muscarinic receptors in the SC node, resulting in tachycardia. So in patients who are already having tachycardia, this drug must be avoided. While the atropine and mevacurium, they are capable of triggering histamine release and result in bronchospasm, skin flushing, and hypotension from peripheral vasodilatation, especially at the higher doses and rapid injection rates. So, how to avoid this histamine release is by giving the injection very slowly and by titrating the dose with the weight of the patient. Now, there is last anesthetic agent. which we must talk about is the local anesthetic pharmacology. Local anesthetic drugs are the drugs which are used clinically to produce reversible inhibition of excitation and conduction in the peripheral nerve fibers and nerve endings, and thus produces the loss of sensation in a circumscribed area of the body. If any one of you has undergone dental extraction or some very small surgical procedure or a very circumscribed area of the body, like on finger, or removal of some foreign body from the body, from a finger or hand, then you can recall that these local anesthetic agents, they are agents which are given in a very small amount, in a diluted, in a dilution, that need to be going to be effect on a very small part of that area, in which, जिसको कहते हैं ना सुन कर देना, तो सिर्फ सुन जहाँ पे हमने कर देना होता है, जहाँ पे हमने सारी की सारी एक्साइटेशन एंड कंडक्शन जो है वो खत्म कर देनी होती है, वहां पर सिर्फ हम लोकल एनेस्थेटिक एजेंट्स लगाते हैं. लाइक आई हैव गिवन यू द एग्जांपल ऑफ द डेंटल एक्सट्रैक्शन. Now, how these local anesthetic agents they are working? So, have you ever seen the injection of the local anesthetic agent like xylocaine or bupivacaine? If not, then these drugs, they are basically available in acidic form with acidic pH, because they are formed in combination with the hydrochloric acid. When they are injected into the tissues, and then they basically undergo buffering, and they unite with the hydrogen ion, and they will release their free base, because the pH is going to be increased, and this free base is very important for us, because this is the only part of the local anesthetic agent that is going to cross the lipid bilayer of the nerve axon membrane. When it crosses the nerve axon membrane, then it will again combine with the hydrogen to form the ionized portion, and this ionized portion is going to cause blockage of the sodium channels, and by blocking these sodium channels, there is going to be blockage of the action potential or depolarization of the nerve axon membrane. It means local anesthetic agent basically are blocking the sodium channels, and they are blocking the depolarization. And by the blocking of the sodium channel and by blocking the depolarization, they are producing their effect. But there is blockage is reversible. These drugs, they are going to be removed from their site of injection, and they are going to be metabolized. It is reversible, and once they are removed, the sensation in that particular area where they are used is going to be restored. ये नहीं कि हमेशा के लिए वो सुन हो जाता है, but it is only for a defined period of time. And this is the structure of the local anesthetic agents, in which there is an aromatic group and there is an amine group, and they are in their intermediate chain, that decides their types. The intermediate chain may be amide or it may be ester. Ester are very few and they are having very short duration of action. The examples are cocaine, procaine, tetracaine, while amides, uh, amide containing local anesthetic agents which we use commonly, the lidocaine, bupivacaine, ropivacaine, and levobupivacaine. These drugs, they are going to be absorbed from the site of injection, and it depends upon the blood flow. The higher the blood flow to that area, the more rapid is the increase in the plasma concentration, and then the greater will be the resultant peak. The rate of systemic absorption is related to the vascularity of the site of injection. It is more in the intravenous than the, or the intraarterial than the tracheal, than It is more tracheal is more than the intercostal. The intercostal is more than the paracervical. The paracervical is more than the epidural, and then it is more than the brachial plexus, greater than the sciatic nerve, and finally the subcutaneous. So basically, the more is going to be the blood flow to that area, the more is going to be the plasma concentration of that local anesthetic agent. How they are going to be distributed? Now they are going to be distributed, of course, through the blood, and the organs of the body which are having less blood supply, like fat and muscles, they show very slow equilibrium with of the drugs with the blood, while organs like brain, myocardium, lungs, liver, they show very rapid equilibrium space with the blood of these with the blood concentration of these agents. I just told you that the esters, they are going to be a very short half-life. It is about 10 minutes because they are going to be rapidly metabolized by the plasmacholinestrases. While the amides, they are going to be metabolized into the liver by the amidases through the process of dealkylation or hydroxylation. And the terminal half-life of these amides, it is much more. If for lidocaine it is about 100 minutes, it means 1.5 hours, while for the bupivacaine it is again more than 3 hours. So it depends upon the type of the surgery we are needing these local anesthetic agents. If for the short procedures we can use lidocaine, but for the longer one we need bupivacaine. These local anesthetic agents, they are very much bound to the plasma proteins, but again, it depends upon the drugs we are using. So, the drugs which bind to the protein in a very greatest degree, then they are very less toxic. While the drugs who bind with the protein in a lesser amount, then they are more and more toxic. We will see uh, how toxic the drugs are in a moment. So basically, these drugs, they are going to produce allergic reactions. They will also produce the systemic toxicity. And this is a very life-threatening system reaction that can cause by the intravascular injection of these drugs. The drugs we inject usually are in the tissues. We do not inject drug into the artery or into the vein. But sometimes it happens that inadvertently these drugs are going to be injected into the artery or into the vein. And that can cause problems. That can, once it enters into the blood, it reaches to the brain, it reaches to the heart, and it produces toxicity. The more these drugs they are in the blood, there are more and more chances of producing the toxicities. How we identify this toxicity? The first feature is the numbness or tingling of the tongue and the circumoral area. Patient may complain of lightheadedness, it becomes anxious, drowsy, or complain of tinnitus. And if still there are more concentrations are increased, then it can alter the consciousness, it can produces fits and convulsions. It is more commonly seen with the lidocaine. And the drugs that is going to cause bradycardia and ventricular fibrillation is the characteristic of the bupivacaine. So CNS toxicity is much more common with the lignocaine, while the cardiac toxicity is much more common with the bupivacaine. Coma and apnea, they can develop afterwards, and it can cause direct myocardial depression and vasodilation, and patient may go into cardiac arrest. This picture actually explains a lot of side effects and the adverse events and the toxic features that are caused by the lignocaine or the bupivacaine. Lignocaine is mostly, or lidocaine mostly affect the CNS. It causes perioral numbness, tinnitus, lightheadedness, confusion, unconsciousness, convulsions, and coma. While the bupivacaine is very toxic, and it affects more into the heart. It can cause cardiac arrest to the patient. But what are the factors which are responsible for these toxicities? It depends upon the agent you are using. You are using, if you are using bupivacaine or lidocaine, then there are more chances of developing toxicity if they are injected into the vein or into the artery. But if you are using levobupivacaine, then there are less chances of the developing this toxicity. Dose is again very important. If you are using more than the prescribed dose, then again more drug is going to be entered into the circulation. Administration rate is also very important factor. If you are injecting very rapidly, then there are more chances that you can inject into the artery or into the vein. Injection site, we just discussed that what sites they are more prone for the development of the toxicity. And even if you are adding vasoconstricted like adrenaline to the local anesthetic agents, then the rate of absorption is going to be delayed, but there are more and more chances of the increasing the duration of action of those drugs. So again, it plays a very important role. pH is also very important. As I told you that these drug agents, they are available in acidic pH, and when they are going to be injected into the tissues, their pH is going to be increased and they become more basic rather than acidic. The more acidic the drug, the more chances are the development of these toxic effects. How you are going to manage this life-threatening toxicity is that ABC rule is the same one. You are going to maintain the airway. Oxygen must be given through the face mask, or sometimes if the patient holds the breath and apnea takes place, then you are going to intubate that patient and artificial ventilation is required. The convulsions can be managed with midazolam or pentothal drugs. So benzodiazepines are very effective in control of convulsions. If the patient undergoes cardiovascular collapse, then that can be treated with alpha and beta agonist drugs like ephedrine. They are very effective drugs. And in case of cardiac arrest, the CPR protocols that are given by the AHA, American Heart Association guidelines, they must be followed. There is a lecture of the CPR also by in our series of lectures, and we will teach you how to do the effective CPR. An antidote that is given if the patient has developed the myocardial or cardiovascular collapse or myocardial toxicity by the bupivacaine is the use of intralipid. And intralipid is available in the as an infusion of 100 ml. It is available in ICU for the nutrition purpose, and in operation theaters, at least 1 to 2 bottles they are available for the management of this toxicity. An initial bolus of 1.5 ml per kg of 20% intralipid is given, and then there is continuous infusion of 0.25 ml per kg per minute. An additional dosage of 1.5 ml per kg can be given if they are required. With this, I'm going to end my lecture, today's lecture, and now if someone wants to ask some question, you can ask. I know that pharmacology is not an easy thing. It takes time to learn, and it takes time to digest. But I tried to make my presentation and my lecture as simple as possible.